All right, super, thank you. So this is our November Lunch and Learn for the New Jersey Doula Learning Collaborative. I'm Jody Green. I'm the Executive Director of the NJDLC, and I am so happy that you are here. We love these Lunch and Learn events because they give us an opportunity to come together in doula community, to talk with each other, to learn together, and to continue to grow and to have a good time, connect with each other, and build sustainably, because we need each other to be doulas long term. We need each other, and we need places where we can gather together. So that's what this Lunch and Learn is for. Today we are navigating, we're talking about informed decision making in labor and delivery, and we had some conversation about what to call this Lunch and Learn, because as doulas, we so often as advocates do find ourselves in the space of navigating that in-between space of what a provider has recommended and what someone may be prepared for, or the decision that they would prefer to make. And as doulas, scope of practice clearly says, I cannot ever tell someone not to do what their doctor has just said to do, because we are trusting our doctors. Everyone on the birthing team has a role. And in our role on the birthing team, we are there as advocate, we are there as support, we are there as ally, but we are not there to make the decisions on behalf of the birthing person or to tell anyone what to do. It's our goal as doulas to make sure that people have the information and the support that they need to make their own best decisions. And the reason that this is so important, why do we talk so much about informed decision making? Because everything we know about trauma in childbirth, everything that's been studied about the effects of childbirth on someone's long-term physical, mental, emotional health, tells us that it matters less than we might think how the baby comes out, or the steps in the process of how the baby comes out. When it comes to preventing trauma, in trauma-informed care, or as I prefer to think of it, in trauma-responsive care, we know that what really matters in preventing trauma is that someone feels involved and included as an active participant in their own care. So we prioritize informed decision-making to support people in being active participants in their own care, so that when all is said and done and they are reflecting on the birth that they have had, they know that this is something that they have done. They know that these are decisions that they have made and that they have given birth. It is not something that has happened to them aimlessly or passively. In a perfect world, when birth goes seamlessly, labor begins, it unfolds at a steady progression, pushing happens within the time that's taught as protocol. There's not a whole lot of unexpected decision-making that may happen. And if we've prepared with our clients and we've shared with our clients and talked through their birth wishes with them, I hesitate to use the word birth plan. We talked on our birth plan call about how we can't really plan a birth. There's what we prepare for, and then there's, as one of my colleagues put it, what the birth fairy bops you on the head with. As doulas, we're supporting in that space between what someone may ideally wish for and the reality at hand and the decisions that are being made in present time. So how do we do this? What questions can we ask to be sure that the right choice is being made at the right time? Danya, may I have the next slide, please? This is the BRAIN acronym. I would like to introduce everyone to the BRAIN acronym. This is something that we can teach in prenatal visits. These are conversations that we can have to front load. Hey, decisions may come up that are different than what we've talked about today. We want to talk about someone's ideal birth experience in a prenatal visit. It's usually the second prenatal visit in my practice. I like to say, okay, here we go. Magic wand. This is your magic wand. Every wish granted. Disney birth. What would you want your birth to look like? And then listen really closely, because you're about to learn a whole lot about this person that you're serving. Some people, those who may be of a more analytical mindset, may say, I would like to have a birth that unfolds in this way. I want to go into labor spontaneously. I want to labor at home for as long as possible until my contractions are 4 minutes apart. Then we're going to go to our birth center, which is half an hour away from here. I'm going to be admitted. I'm going to do these things for comfort measures. I'm going to push a baby out. I know I want my baby skin to skin right away. I know I want to breastfeed. The end. Disney birth. They have thought it through. And then on the other hand, you may have someone who says, I really don't know. And I really don't want to overthink it. Because if I've overthought it and I have something that I think I want to do and it doesn't happen that way, I'm going to be disappointed. And because I don't want to be disappointed, I really don't want to make any decisions in advance. I just want to go in blind and figure it out as they come. That's important for us to know as well, because as doulas, if someone does not want to take a deep dive for their own reasons into these plans that they might wish to make, we need to know that so that we are prepared to navigate the decision making in the moment as it comes up. And in these prenatal visits, after we've talked about birth plans, I like to talk about the BRAIN acronym and what we will do when a decision making moment comes up. I also like to use the words informed consent. I had an interesting conversation with a colleague who's also a doula trainer, who once upon a time said, well, I'm kind of reluctant to use the words informed consent because consent for many people just has such a sexual connotation to it. I can see her point. Yes, it does. We do teach from the time children are very small. You are the boss of your body and no one may touch your body without your permission, unless it's your doctor and they've still asked permission and they're doing it as a matter of your care, right? These are conversations that we start having with children when they're very small. Why do we stop having them with adults? Someone's body does not cease to be someone's body simply because there is a baby emerging from it in the moment. I think if we understand the context of informed consent in a sexual context, why can't we cross-apply it into the birth world? Because our bodies are still our bodies, and someone's vagina does not stop being someone's vagina because they're giving birth, right? So with informed consent in mind, let's say that a moment has come up, and here's the example I'm going to use. I'm going to use the example of a person with high risk factors that have led their provider to recommending that their labor be induced. Now, it is true that in New Jersey right now, we have very high induction rates. We have an epidemic of induction. And it's also true that failed induction is one of the leading contributors to cesarean birth. Statistically, if you have an induced labor, you have about a 50-50 shot at having a vaginal delivery, about a 50-50 shot at having a cesarean delivery. Induction doesn't always work. That said, there are times when the benefits of induction outweigh the risk of induction. And one of those times is if someone has medical risk factors that make induction the recommended protocol. But someone receiving the news, hey, your blood pressure's been really high your last 3 visits, and today there was protein spilling into your urine. And with these factors in mind, we're concerned about your well-being and your baby's, and we want you to begin the process to induce labor. Someone may have their own emotional process around that, and that makes sense. And we as doulas are there for that conversation to give the empathy. Yes, this is different than what we've talked about before. Yes, I can understand why that would be upsetting to you. And even, yes, I can understand why the way that that was said was upsetting to you. That was not presented well, and that was really unfair. So let's talk this through. Because we are not, as doulas, going to say, trust your body, trust your baby, trust your birth in the ways that we so often do when what's present at hand is a risk factor that makes someone's safety at risk. This is the time when we need to have these conversations. So we start with, is what's going on an emergency? If you are in a labor room, an emergency might look like 7 people running into that labor room door, one after the other, each one attending to a different task. One is handing scrubs to a partner and giving them instructions on what to do. The other is unplugging the monitor, and yet a third is releasing the brake on the bed so that it can be pushed out the door into the operating room as quickly as possible. Everyone has a task to do. If what's happening is a midwife calmly standing beside the bed saying, next time I come in, I might want to have a conversation with you about breaking your water. This is not an emergency. This is time that we can have a conversation about it. So is what's going on an emergency? No. Is everybody okay? Parents okay? Babies okay? Okay, cool. Let's have a moment and have this conversation. The client can always ask, why? Why? And that's the first question we're going to go with. Why is this recommendation being made? What would be the benefit of our making that decision? In the case of induction, when someone has preeclampsia, the benefit of making that decision is we are using the means that we have to ensure that both parent and baby are safe and thriving. We want to make sure that everyone is okay when all is said and done. And let's be really clear, we're not setting the bar at everyone survived and so it was okay. We're aiming for healthy, thriving babies and non-traumatized parents in this process. So what would be the benefit of our doing it this way? Is it a matter of health and safety? In the case of induction and preeclampsia or gestational diabetes, it probably is. If their complications have reached the point where their provider is recommending induction, but rather than assuming that, let's ask, why? What's this recommendation being made for? What would be the benefit of being made that way? In the case of a midwife saying, I might want to break your water, what would be the benefit of doing that? Well, in the case of an induction, sometimes the releasing of membranes is recommended as a step that might make labor happen a little faster. That's not a very strongly evidence-based practice, but it is something that might be recommended. Or in the case of someone who's 9 centimeters and they have a bulging membrane, the benefit might be that the midwife is not sitting in the splash zone when that water does release. So there might be benefits to this. What risks do we need to be aware of? What risks do we need to be aware of in this decision? In the case of induction, there are risks. One of the risks might be it doesn't work. Another of the risks might be that parent or baby may not tolerate one of the steps that happens along the way. Those are risks that, again, the client can ask questions about. And let's be clear that whenever possible, we are encouraging birthing people to ask questions for themselves, and we are involving and including partner participation when these questions are being asked. We can encourage for questions to be asked. What questions do you have for your provider about risks that you might need to be aware of? Are there any alternatives? A is for anything else. And going back to risks for a second, if anyone ever says there's not any risks, your client can ask that person to leave the room and send someone else in, because there are no procedures at all that are completely without risk, including if I stand up from my desk right now and walk across the room, there is a risk that I will trip over my own feet and fall on my face and break my nose. It's not a very substantial risk. I'm glad that it's not a very substantial risk, but it is one that exists. And saying, oh, there's no risk whatsoever is not the reality at hand ever. So we can always ask about the risks and be informed of those along the way. A, are there any alternatives? Is there anything else that we could be doing? Is there another way? Is there something that we haven't tried that we might be able to try first? Here's why this question is so important. I'm going to use the example of one hospital, and I won't name them, but they're a hospital where I've attended often. In this hospital, they have 15 labor and delivery rooms. And in those 15 labor and delivery rooms, they have between 500 and 600 births a month. Let's do the math. 500 births 15 labor and delivery rooms. This is a lot of births. And there are things that happen when a facility has this many births. Providers begin to develop habits. I'm not vilifying this because so do doulas, right? We do something 1,000 times and you kind of get into the way that you do things because it's the way that you do things, because it's the way that it's always been done. And sometimes there's another way to do it that hasn't been mentioned. And it's okay to ask that. Is there another way that we can do this? Is there something we haven't tried? Now, to be clear, I'm not going to be the person asking a provider to do something that they are not comfortable doing or that they have never tried before. That's why we're asking the provider, is there another way that we can do this? Is there something we haven't tried? Is there an option that we're not aware of? An alternative that might also be on the table at this time? I is for instinct. If you have ever had a gut feeling about something, you know what that gut feeling feels like. Pregnant people can have gut feelings too. I might not ask out loud, what does your instinct say about this? But I might ask, what do you think? How's this feeling to you? Are you inclined one way or another? People will tell you. If someone feels, I really do feel okay, and the doc said that we have more time, and if it's an option to take more time, I'd really rather do it that way. I'm not ready to take the next step. All right, I'll listen to that. Or is their energy holding out? Do they feel like they've got the spoons to keep going for a while? Cool. As long as that's on the table as an option, that's something that we can ask about doing. And at the same time, someone will also tell you when their gut feeling is, yeah, you know what? I really am feeling like I need help here. This is just something is weird, and I want to do whatever it is they've just suggested. I'm going to go with that. I will trust a pregnant person's gut feeling over my intellectual knowledge any day, any time. And that needs to be taken into the considerations when we're making decisions. Now, let's differentiate between instinct and denial. Because one thing that can happen when someone is in a moment where risk factors are present, and the doc has said these risk factors are present, perhaps the nurse has echoed in, these risk factors are pregnant and we need to do something. Someone's response might still be, no, I don't want to. And this is when we look at, is this an instinctive thing or is this a denial? That the reality at hand really truly is that there is a risk going on here. And sometimes birth needs help. And this is one of those times. So navigate delicately in asking the instinct question and maybe consider evaluating that yourself rather than it being something asked out loud. We're asking how someone feels rather than asking what their gut feeling might be. And N, not now. Is it an option to do nothing right now? Because often it's an option to do nothing. Let's go back. 15 labor and delivery rooms, 600 births. How many hours does that come out to per birth? The average first labor, average, takes 2 midnights between, oh, I think these are contractions, and baby being on the outside. 2 midnights is normal. It is very normal for a first-time labor to take 24 to 36 or more hours, and that's okay. But in a clinical setting where time is of the essence because someone else is waiting for the room, the option to do nothing may not be considered frequently, or it may not be spoken out loud as an option if it's not asked for. Pardon me. So we can ask, is it an option to do nothing right now? So now we've navigated the brain questions. What would be the benefits? What would be the risks? Are there any alternatives that we need to be aware of? What's the gut feeling on this? Is it an option to do nothing right now? And then this step is very important. I encourage the families I work with, after we've talked through all the things, I cannot say everybody leave the room, but the patient can. In the New Jersey Patients' Bill of Rights, it very clearly states that patients have the right to privacy in their decision making. Not only do they have the right to informed decision making, as long as it is not a life-threatening emergency, people have the right, and I will say people have the right and responsibility to practice informed decision making and to think things through. So they can ask everybody to leave the room, because we're going to think about this a minute, and then we'll let you know what we've decided. And it is that step that lets the family own their own decision. Yes, we have heard what our doc has recommended. We have heard what our midwife has recommended. We understand the risks and benefits. This is the decision that we're comfortable making at this time. And then they are speaking for themselves. This does good on so many levels in that, one, it gives the ownership of the experience to the person whose body it is happening in. It is permitting people to speak for themselves and navigate conversations with their provider in a way that leaves people feeling empowered. If we can do that for someone, that is a gift that lasts a lifetime. Second, it also makes it abundantly clear that this is not a doula telling someone what to do, but someone making their own decisions with informed decision making, considering the reality at hand with all of the information necessary to make this decision. And this is how we prevent birth trauma. BRAIN acronym: everybody leave, discuss and decide, and then inform the team of the decision that has been made. Now, I will also say that as doula, if someone has asked everyone to leave the room, that means me too. I want the doctor who has just been asked to leave to see that I am leaving right behind them. And what I am not doing is having a conversation behind the doctor's back about not doing what the doctor said, because often that is a misperception that clinical providers have about doulas. So I want that doc to see I left the room right behind them. Now, I'm probably going to be back in the room before they are so that I can ask, hey, what do you think? And because it might be a little bit before the doc comes back in, but I want to make sure that that family's had a private moment to discuss their decision making. May I have the next slide, please? And I think it's the last one. So let's talk about it. I'm going to stop the recording for us to talk about it. Before I do that, I want to make sure everybody's aware of upcoming events. Doulas and Desserts is happening this Friday in Trenton at 6 p.m. If you've not already registered, you can go to njdlc.org